The mechanical contractions of the heart are driven and coordinated by the depolarization of cardiac muscle cells. As the cells of the heart depolarize, they induce nearby cells to depolarize as well, causing a wave of electric potential to spread out and away from the original source. Now, when a pair of electrodes is placed on the chest, you can measure whether the wave of electric potential is spreading, on average, towards one electrode or towards the other. In a way, you can think of it as simplifying the three-dimensional spread of electricity to a single dimension. The cells are either depolarizing towards the positive electrode or towards the negative electrode. And you can track how the magnitude of that vector changes over time as electricity spreads through the heart. This is the basis of the electrocardiogram, or the ECG. And in order to diagnose pathologic conduction on the ECG, well, you first need to recognize the normal waveforms on the ECG and what they represent. The electrical signal normally begins at the SA node and radiates through both atria away from the SA node. This creates a deflection on the ECG known as the P wave. The flow of electricity progresses until it runs into the fibrous skeleton of the heart that insulates the atria from the ventricles, all except for a small strip of conducting tissue known as the AV node. Now, in order for the electrical signal to reach the ventricles, it has to pass through the AV node and bundle of His immediately downstream. But this tissue is specialized to conduct electricity very slowly, creating a delay between atrial and ventricular depolarization that allows the atria to finish contracting before the ventricles begin. Because the signal reaches the AV node at some point during the P wave, the time between the beginning of the P wave and the beginning of ventricular depolarization approximates that delay at the AV node. This is known as the PR interval. Ventricular depolarization is highly organized to optimize the efficiency of cardiac contraction and progresses along the branches of the bundle of His. In other words, first the septum depolarizes, then the apex, then the superior posterior portion. And this usually creates three distinct deflections, known as the Q, R, and S waves, respectively. And together, this creates the QRS complex that depicts ventricular depolarization. Because of the plateau phase of cardiac myocytes, there's yet another delay before ventricular repolarization. And repolarization is less organized than depolarization, but usually its deflection matches the average deflection of the QRS complex. This deflection is known as the T wave, and the duration of the plateau phase of cardiac depolarization is best represented by the QT interval. If you're wondering, by the way, the atria do generate electric potential when they repolarize as well. It just doesn't show up on the ECG since it happens during the much more powerful ventricular depolarization. Now, cardiac pathology can be diagnosed not only by the absence of normal waves, but also by abnormal timing of cardiac conduction and abnormal shape of the waveforms, known as morphology. Additionally, regional assessment of abnormal repolarization, namely the T waves and the preceding ST segment, are critical in evaluating the vascular territories of the heart for ischemia or myocardial infarction. Remember, the ECG shown here is only a one-dimensional perspective of the flow of electricity through the heart. It only measures whether the current is flowing towards one electrode or the other on average. But you can mentally recreate the pattern of cardiac conduction in all three dimensions by using a series of paired or single electrodes, each of which provides a different perspective on cardiac conduction in either the horizontal or the frontal plane. And this, my friends, allows you to assess abnormal conduction in specific regions of the heart.